Okay. So I'm Jen. I'm one of the PTs that work on the ARC here at the Bethlehem campus. I've been there for about 5 years. So today I'm just going through a review of neuroplasticity principles for rehab post-stroke, and then different interventions for upper extremity, lower extremity for gait, and then a review at the end of motor learning. So after we go through what interventions we can use for our patients and why, then like how else can we structure our interventions to improve their long-term motor learning. So if at any point you have questions as we go through, just let me know. And then again, anybody listening in, type in, and every now and then I'll check back on that. So do you have or as they get you the PowerPoint slides as we go through? Oh. So anyway, just because I know you can't see from up here, but again, the objectives and then the outline are the neuroplasticity principles and understanding why they should be underlying our treatment interventions and how we can use them to do that. And then upper extremity prognosis and treatment interventions, lower extremity recovery in regards to gait training, and then again, the review of motor learning. So I know you don't have all the slides yet, but the 10 principles of neuroplasticity came out in 2008. And so what they found is that there are these 10 principles that most of them we can have a direct effect on when we design our treatment interventions. So the first two are use it or lose it, and use it to improve it. So those are pretty self-explanatory. Most patients would understand that as well, that if we don't use the body part or the whatever is affected from the stroke, if we're not using that, then it won't get better. And what they've also found that post-stroke, if we don't use it, it actually gets worse over time. So if it's something important to let our patients know, like, yes, I know it's difficult for you to use your arm, but if you don't lose it, not only will it not stay the same, but it also won't get better. So then again, in order to improve it, we have to use it. Then age and time are also on that list. So again, age is something that we can't have an effect on, but to understand that as people get older, it is harder for them to heal. Time means that the sooner we can start them in like a good rehab program, the better outcomes we can get. Transference and interference. So these two relate to how we can structure interventions to either promote and improve long-term motor recovery, or depending upon how we structure things, it actually interferes with that long-term motor recovery. So transference would be an example of that is if we use eStim, like in conjunction with our treatment interventions to improve that sensory input, we can get an improvement in that motor output. So we're using things in a way to improve outcomes. Another example of that is when we talk about recovery versus compensation. So if we're optimizing and setting up the patient's plan of care, which we'll get to later on, to promote recovery, then that's also under that idea of transference. Interference is more under the lines of compensation. So if we're structuring their treatment interventions and doing things in a way that negatively impact their long-term motor learning, that's under their interference standpoint. So then the four that are left over are specificity, intensity, repetition, and salience. So then these are the four that I found to be like the most important from day to day. So again, the other ones are important and they're there, but we don't maybe necessarily use them quite as much as these four individual components, and then that's what we'll go through next. So specificity really just means that we get better at specifically what we practice. So if we want a patient to get better at walking, that's what we need to do. If you want them to get better at ADL training, that's what we need to do. So this talks a lot about that interference component or transference component of recovery versus compensation. So, if we're specifically wanting to improve right upper extremity function, we have to get that arm working in that way. If we're kind of doing things differently than they were before, then that's more under those lines of compensation. So again, in order to specifically get better at a skill, like that's what we need to practice. The other important thing is that patients need to be learning skills and not just repeated movements. So an example of this would be if you're trying to work on ankle dorsiflexion and you're just having the patient do ankle pumps. Well, what do they really care about just moving their ankle? So maybe I'll kick you a soccer ball and have them kick it back. So now it's not only just that movement that they're doing, but it's also that skill in regards to a functional task. So yes, we need them to get moving more often, but we also want to make sure that they're doing that in that environment of a skill. And that's one way that we can improve their long-term motor recovery. In intensity, so when patients are medically stable, what they found through the research is that we can have patients work at fairly high intensity. So 60 to 85% of heart rate max, 70 to 80% of heart rate reserve, and the calculations are on the slides for you. So the idea is that instead of just having patients come in and do really easy therapy and they're like, oh yeah, this is like pretty easy, like that's something that we don't want to focus on, because in order to induce all these neuroplasticity principles, we need them to be working at higher intensities. If patients are on medications that blunt their heart rate response to exercise, which a lot of these patients are, then we were looking at 15 to 18 out of 20 on the Borg RPE scale, which is pretty high. Like even, when you think about if we go to the gym and work out, like are we always exercising at that intensity? Like maybe not. So the idea is that once patients are medically stable and like they're good to go from their doctors, like we need to be pushing them, again, as appropriate. Another article even looked at 13 to 17 out of 20 on the Borg RPE. So, and then why do we want to do this? It's to induce neuroplasticity, like all these components of neuroplasticity principles. It also is a way that we can improve their activity tolerance. So as we know, it's the next principle is repetition. We need a lot of repetitions for patients post-stroke. So a lot of people come in and they have decreased cardiovascular status. They can't do much. So then how can we get all those repetitions if they can't tolerate more than maybe like a half hour at a time? So the other component of working with the intensity aspect is that over time, their endurance or their activity tolerance will get better. And then over time, they can also tolerate more repetition of activity. And then another component of intensity is that we also want to be talking with our patients about decreasing the risk of secondary stroke. So as we know, once you have a stroke, you still have increased risk of having another one. So then what can we do to help them from that standpoint? So again, if we get them set up with a good exercise program in Q rehab, continue that in outpatient, explain why this is important and help them continue from there, then we can also decrease the risk of secondary stroke. So then repetition. So what they found in the literature is that hundreds to thousands of repetition is what we need our patients to be doing a day. So like not in a week, not in a month, but like hundreds to thousands of repetitions in a day. So typically hundreds of repetitions for like ADL and like functional task practice and that component, and then thousands of steps per day in gait training. And we'll get to more of that a little bit later on too. Then another important component is salience or motivation. Like what do the patients like to do? What would they be engaged in? If you have a patient, again, just doing ankle pumps, they're probably like, why am I doing this? Like, what's the relevance to me? So talking with your patients about what do they like to do? How do they like to spend their time? How can we modify those activities to incorporate that into their therapy sessions? So they found, and some of this is with animal models, is that there is actually a motivational component of the brain that is linked to improvements in stroke recovery. And it also improves attention to task and the patient's desire to problem solve. So as we know, when we learn things, you learn a little bit by trial and error. So you have to make some mistakes to figure out, okay, well, was that a good practice, part, or maybe not so much? What do I need to do to get better? So if the patients are engaged in the activity and they like what they're doing, then they're more willing to be cognitively engaged in that whole process. So when we look at walking, most people want to get back at walking. So there's really not any difficulty finding that motivational component there. But again, if we have them doing just like arm exercises or like towel glides, well, maybe they're like, well, why am I doing this? Like, I'm kind of bored just sitting here. So one, they won't be as engaged. Two, they won't get the best outcomes. So it challenges us from a treatment intervention standpoint to really think about, well, how can we change this task? So instead of just towel glides on a table, we'll maybe make a mess on purpose. Spill some water, put beads, put rice, or whatever, anything that they might have to clean up at home, and then now have them clean it up. So they're still doing that same activity, but you're putting it in the context of a functional task and something that's relevant and meaningful to them. Even doing like some type of active assisted range of motion, anything else like that we can come up with that is linked to what they like to do is definitely going to help improve their outcome. So again, as a quick recap of that, it's a specificity, intensity, repetition, and salience, or that motivational component that I found to be the most helpful in what I do on a day-to-day basis, and also educating the patients on, okay, what are these components? What does it mean to you? How can you continue to use these components to improve your motor recovery when you're not in therapy? So again, when patients are in the ARC and then they go home, I'm like, okay, well, what are you going to do when you go home? They're like, I don't know, I haven't thought about it yet. They're kind of like, well, now what do I do? So if we teach them what these components are and why they can use it and how, then it helps them transition at home. And then the same thing with outpatient, then you can help set them up for whatever progress they made here and then to continue to do that when they're home. So based upon like all of your experience and things that you've done here, let me just see if there's any questions. Okay. Do you find that you typically have patients who you're focusing more on recovery with or more on compensation techniques? Or what have you found to be like applicable to you here?
I would say both, depending on the patient level. Do they have an active movement? Do they not? Are you focusing on just initiating movement or not? So I feel like it depends on
It depends. Yeah, so I agree. So it does depend. Like the general idea is that we would want to shoot more for that recovery, like as much as possible. But obviously there are many factors that play into that. So on this one slide, it's the circle slide. I just put down some things that can play into that. So again, it's not the be-all end-all list, but like Bree said, it's a combination of things. So ideally, we do want to still shoot for recovery as much as possible. However, based upon some of these things, compensation may be more of what we need to focus on. So safety is one. So for instance, like on the ARC or even an outpatient, if you're doing a lot of working on walking without a device and they need to be home safely on their own, maybe you do need to use a walker or a cane to keep them safe. So it's not the ideal situation, but it's what we need to do to at least keep them safe in the time being. Prognosis. If they don't have a good prognosis for motor recovery, then you would need to focus a little bit more on compensation, safety techniques, and things like that. Cognition is a big one. So as we all have had practice with that or experience with that, if patients can't follow through on what we're asking them to do, you can't, or it's not realistic to have the same expectations of what they'll be able to do. So if they don't have good memory, if they don't have carryover, if they can't stay awake, if they have poor arousal levels, like all of that factors in. So again, just some other things to kind of think about when we look at recovery versus compensation. And because there are so many variations in how people present post-stroke, it's a lot based upon our clinical decision-making and judgment in terms of what we should do, when, and why. Okay, so what are some activities or interventions that you guys use here for upper extremity assessment and treatment? Or a combination, or treatment interventions that you do, like post-stroke.
Again, depending on the level, depends on when you start the patient. So if they're lower level, we're just trying to enhance any kind of motor movement at all, like advanced class heavy, we're just trying to initiate the movement. So we start with bionets or stiff if they're able to have that. If they have more of functional movement, then we're going to focus on those important tasks, like getting them back to any kind of ADL or any kind of qualification. So we focus then on strengthening versus, if it's still like proximal, we'll have to look at that as well.
Yep. So I don't know if everyone else looking in can hear that, but like Bree said, it's a mix of everything based on what they're able to start with. So if you're looking at strengthening versus task practice and acute stroke, which one do you think would have better outcomes? So if we have like a group of patients post-stroke, some were focusing on strengthening, some were focusing on task practice, which group do you think would have better outcomes? Yeah, the task practice. So this one particular study was looking at the differences between strengthening interventions, task practice interventions, and like standard care, which they kind of grouped as like a mix. And then they looked at pre-test, post-test, 6-month follow-up, and 9-month follow-up. And then those are the outcome measures listed that they looked at. So one of the important things from this is that it's not just the immediate post-test that the patients did better with who were in that task practice group. So one of the important components that I think is good for us to know and to teach our patients is that we're also looking at that 6 and 9 month motor recovery down the line. So what we can do now can optimize their long-term motor recovery, and that's really what we're shooting for. So one of the other articles I had read about motor learning was that if we're structuring things to improve their long-term motor recovery, it actually makes their short-term performance worse in comparison to the group who is focusing on short-term performance. So that wasn't in this particular article, but on this graph, it shows that the post-test, there isn't a difference between the strengthening group and the task practice group, but it's at 6 and 9 months down the line that's when you see that improvement. So again, the main idea is that as much as possible, we need to be engaging our patients in that task practice. So it typically engages more of the salience or motivational components because it's something functional, in addition to having the high reps and intensity. So another article I found was looking at, well, what can we do to kind of come up with an algorithm for patients post-stroke for upper extremity functions? Like, what are some things that we can look at to give us an idea of, at 12 weeks, would the patient be likely to have a complete, notable, limited, or no recovery? So this article I thought was interesting because they looked at what they call a SAFE score, and that SAFE score stands for shoulder abduction and finger extension. So at 3 days post-stroke, they looked at that just general manual muscle test score. So it was a score out of 10. And then again, on this algorithm here, based upon what they scored, they could figure out fairly well, and I have the information here, in terms of, again, complete, notable, limited, or no recovery at 12 weeks. So what they worked the algorithm so that there was a very limited like mix of groups. So what I mean by that is that the people in there was very little carryover or overlap, I mean, between the complete and notable group, or like notable and limited group. So the algorithm has an 88% specificity and 73% sensitivity. So overall, it's pretty good. And so again, what they're looking at is if the safe score is 5 or higher, then the patients are most likely to have a notable or complete recovery at 12 weeks. So the TMS is transcranial magnetic stimulation, and what they use that here for is to activate part of the brain to see if the cortical motor tracts were intact. So again, if a patient has a lot of weakness, but the motor tract that's sending all that information out is intact, then they have the potential to get that neuro recovery back. And that's what the MEP stands for, the motor evoked potential. If they did the TMS and they found that the motor evoked potential was absent, then they looked at doing a form of an MRI to break out, okay, well, would they have a limited or no carryover? So without actually being, for us, you know, it's not, we don't have access to the TMS and the MRI as they did in this study, but the main idea is looking at, okay, it's 72 hours post-stroke, then are they above a 5 out of 10 manual muscle test or under? And then we can use this to help guide. So I know we're trying to do a little bit more work in terms of tracking patients along the continuum of care, and then to have a better idea of what the prognosis is, and then that can help guide, okay, well, do we need to focus a little bit more on compensation, or should we avoid the compensation as much as possible and focus on recovery instead? Any questions on that so far, like on that particular study? I mean, if you're looking at manual muscle tests, I think it's a fairly straightforward algorithm. And okay, so then the next slide was another study that was done a few years later, and they used that PrEP algorithm to guide treatment interventions. So again, this is a helpful slide, I think, especially for people like newer grads, if you're not quite sure where to structure your treatment interventions. They looked at taking the components of that SAFE score. So can they move their arm at all? Do they have any abduction? And then the next component is, do they have any finger extension? And then based upon what the patients are able to do, like we were saying, if they have no active range of motion, then this is where they're focusing more on the compensatory techniques up front. So making sure that the patients are knowledgeable about range of motion and positioning components. If they do have some abduction but no finger extension, doing more gross motor movements, using their arm to stabilize things versus, you know, focusing on fine motor control. Use of eSIM, motor imagery, or mirror box treatments. And then if they're able to move their shoulder and their fingers, then they'll look to doing higher level activities. And then on the bottom right of this image, it has the shoulder pain prevention and management. So we're going to always kind of keeping an eye out for that in terms of what may predispose the patient to shoulder pain and how we can structure or keep an eye on that. So then the next few slides just go through each one of those components. So again, if the prognosis is poor, no motor recovery, then we're really focusing on that compensatory strategy technique to prevent complications. So making sure that the patients and their families know how to range their arm, how to work on positioning, and then we can set the goals accordingly from that aspect. So if the patients really don't have any motor return, then they can range their elbow on their own. The articles were suggesting that they don't range their fingers or their shoulder on their own because their other arm or their other hand isn't adequate to stabilize all the other joints. So explaining that to patients and their families and how to help them take care of their arm. And then if they are able to walk or to stand and do more activities like that, a sling, like a give more sling, is helpful to support their arm and allow them to be upright in those other activities. So again, just some pictures on like passive range of motion images of what not to do. So again, educating the patient and their families on how to have someone else help them range their fingers and their shoulders. And then just a quick review of risk factors for shoulder pain. So again, the patients with the least amount of motor recovery are more likely to have the shoulder pain because they don't have that active range of motion to keep the joint where we need it to be. So again, any inattention impacts that as well because they're not even aware of where their arm is in space. So now going up to the next part. So they have limited prognosis. Then here we're trying to promote just movement. So gross strength, gross range of motion, some compensation, but still trying to work on what they're able to do as much as possible. So again, using their arm more to stabilize objects than it would be to open anything or that fine motor control. And then for the top two groups, so again, if they're above a 5 out of that SAFE score and they have a notable prognosis, then we're really trying to focus on promoting function. So these are the groups that I would say try to minimize compensation as much as possible up front, educate the patients on why. Like, yes, we know it takes a lot longer to do all these tasks than it did before. It's easier for you to just use your unaffected arm post-stroke, but this is why we don't want to do that. So again, if patients are focusing on compensation techniques, it takes away from their body's ability to really rewire those recovery pathways that we want them to get better at doing. And then we can look at using percentages for goals in terms of what items they're doing and how much. So then for complete, again, the goal is to look at preventing compensation and promoting use as much as possible. And then again, just some examples for goals. So then just as a summary, if we're looking at that SAFE score, which is 72 hours post-stroke, then, and we can even come back to what their SAFE score is like a little bit later to track progress as far as the shoulder abduction and finger extension. Then we're looking at promoting normal use or promoting safe function, promoting movement, and more compensation for the lower categories. Okay. Any questions on that or any other comments or things that you guys have done? So then for gait training. So why do we care about gait training and why do we care about walking speed? So as most of us have probably heard by now, walking speed is considered to be the sixth vital sign. So increases in walking speed are linked to an improvement in independence in ADLs, less likely to be hospitalized, less likely to have a hospital readmission, more likely to have a discharge to home versus a discharge to SNF. So if we're trying to improve someone's walking, improve their walking speed, then how can we actually do that? So if we're looking at those 4 components of the neuroplasticity principles, the specificity, intensity, repetition, and salience, the specificity is looking at doing as much as we can to create those sensory motor components of gait. So what does that mean? So we're looking to get a step-through gait pattern as much as possible. So helping them to, whether in acute rehab, we use the body weight, we use different AFOs or braces or extra TheraBand wrapped up around their leg to give them that assistance. We'll help them if we need to get one foot in front of the other. So from the different research articles that I've read, and I've implemented this with my patients and I've got much better results than doing anything I ever did before. So they were saying that if we focus on this and get the patients used to walking with a step-through gait pattern, then a lot of other things will carry over. So even though we were looking at how the specificity of training is that if you just do walking, that will get you better at that, one of the articles actually found that patients improve their static standing balance and they improve their transfers just by focusing on all that walking training. So it actually helped carry over to a couple different areas. And then we're also focusing on assisting like proper kinematics, meaning trying to reduce the knee hyperextension as much as possible. And then as much as we can, have the patients walking at a high enough intensity to meet that 15 to 18 out of 20 in the Borg RPE scale. And what they found is that the higher repetitions that patients can get with walking, and again, as they improve and get more endurance and stronger, they can tolerate more repetitions of walking, that if they can get 2,500 to 3,000 steps over ground, or potentially even 4,000 to 6,000 steps on a treadmill, then that would be like the overall goal that we're trying to meet. So obviously not everyone can do that up front, but if we can reach that point, then we're doing as much as we can to improve their long-term motor recovery. And like I said earlier, there really isn't, I haven't come across anyone who hasn't wanted to get better at walking, so there's really no issues from that motivational component. So this next article was looking at how many steps per day on average do inpatient rehab facilities get, and then if they are focusing on increasing stepping practice, how many steps, again on average, could these facilities get with their patients. So what they found is that they looked at 201 patients less than 6 months post-stroke, and what they found was that people were getting less than 300 steps per session, which is low. So then they looked at how can these different rehab facilities implement an increase in stepping practice, and they were able to increase that up to roughly 1,500 steps per session on average. And the patients were also walking at an intensity of greater or equal to 14 out of 20 on the Borg RPE. And then what they found with all of that is that they looked at the 6-minute walk test, Berg balance scale, and then the FIM for bed mobility, toilet transfers on walking, and then all of those components had significant improvements at the end of when the patients were on their rehab facility. So again, looking at so improves their overall endurance and improves their transfers as well. And then the next slide of looking at the admission level of assistance and DC level of assistance. So when they inputted this data, they were looking at, okay, on the FIM score, so like the DC level of assistance on the left-hand side, that's looking at FIM level of a total all the way up to like a MODI or independent level. And then the admission level of assistance is the same idea. So the patients who came in at the lower FIM scores of like a 1 or 2, some of them were able to progress up to walking at a supervision level when they left. And then if you look on the top, on the bottom, or sorry, on the far right, that's looking at the average steps per day. So only 2 patients came in at a total FIM and left at a total FIM, but they were also only walking a few hundred steps per day. Then some patients were able to come in at, again, a total and then leave at a supervision level, and then those patients were getting thousands of steps per day. So it just, again, showing how if we get a lot more stepping practice in per day, then we can improve their overall outcomes. They also looked at, or another study also looked at chronic or patients with chronic stroke. So again, if we have patients coming in with another issue and then now but they have a history of a stroke, going back and looking at, okay, well, how many steps of walking are you getting per day? How can we increase that? When those patients got up to walking 6,000 steps per day, they still made improvements in their walking pattern, even in the chronic stages of stroke. Okay, so if we're saying, okay, we need our patients to be walking, and depending upon how well they're doing, maybe we don't really know where to start with as far as like what type of treatment interventions to use or how much to help them, then the general idea is that we can use as much as we need to up front to help them get that step through walking pattern. And then as soon as they don't need that extra assistance, we can back off a little bit. So a treadmill or body weight support over a treadmill or over ground, a TheraBand flexion wrap. So I have a picture of that coming up, but I use a TheraBand wrap up around their whole leg. So if they have difficulty advancing their leg, that when the TheraBand is put on stretch and then it recoils and it helps them bring their leg forward, it also helps to decrease the knee hyperextension. And then we can use different equipment to help advance their legs. So as we know, patients don't want to weight shift to one side, or if they have difficulty lifting their one leg forward, then one technique is actually attaching something to their shoe and like advancing their leg for them. So if you can sit on a stool, if you have a treadmill, treadmills are easier to sit on the stool, and you can help advance their limb, get their heel strike. But then you can also do it in the body weight if it's over ground. AFOs, any hands-on technique, or even a single point cane for light touch cue, which helps to improve the muscle activation on the affected side. So again, the idea is that doing as much as we need to up front, maybe if we're using the body weight or the treadmill, taking them out of it, seeing how they do with that, and then going back if we need to. So what are some things that you guys do here for gait training post-stroke?
Well, we definitely use the treadmill a lot.
Okay.
I would say we also use our solo
Okay, so we left off at talking about why, like, what are some advantages of walking with a step-through gait pattern? So some responses were puts the hip flexor on stretch to help it activate. It helps to improve the sensory motor components of gait. So do you ever find that patients at post-stroke have a difficulty weight shifting side to side? Yes. So when we look at specificity, if we're like, okay, the patient has difficulty weight shifting side to side, let me work on that weight shifting side to side. What do you think the patients got better at, walking or weight shifting? They got better at weight shifting. So what I learned in school was doing a lot more of those pre-gait exercises. So like, let me help them bring their one leg forward, bring their one leg back. Let me help them weight shift. Step sideways, step forwards, backwards, things like that. And so what the research is really demonstrating, and I've seen significant improvements with my patients, is I've like stopped doing all of that. So I'm like, okay, let me get them in the body weight if they don't have enough upright support to walk outside of the body weight, and I tell them just get one foot in front of the other and I'll handle the rest. So the idea is that what do they have to do from a weight shifting component to get one foot in front of the other? Like, do they have to weight shift long enough to get one foot in front of the other, or does that not matter so much? Yeah, so in order to get one foot in front of the other, they have to spend an adequate amount of time on that stance leg to swing the other leg through. So again, if patients don't want to spend a lot of time standing on their affected leg from the stroke because it's weak, maybe it buckles or hyperextends, then they're not going to take a long step with their unaffected side. So we all know their unaffected side can move just fine. So it's also taking a look at their walking pattern from, okay, well, what are their impairments post-stroke? Why might they be walking the way they do? Factoring in that weight shifting component. So they don't have enough strength on the leg affected from the stroke. They may have difficulty bringing that leg forward because there's just not enough strength in all those muscles to get that leg forward. The other potential is that maybe they don't want to spend, for whatever reason, a lot of time on their unaffected leg, and they don't have the time from a walking perspective to adequately swing their leg through. So if we give our patients a lot of cues or a lot of instructions, like how well do they often respond, like how well do they often perform if we overload them with too much info? Typically not too well. So if we can keep the instructions a little bit more simple and just tell them, just get one foot in front of the other, then they're not focusing on the weight shifting. They're not focusing on all the muscle activation that they have to do in order to get that task done. You're giving them more of that functional task cue. So that's the big reason why working on the step through gait pattern is helpful, because in order to do that, other things kind of have to be into play. So it basically forces them to get that weight shift without having to give them step-by-step instruction on how to do that weight shifting. The other component is that when we, again, like if we're looking at a normal walking pattern, it is with one foot in front of the other. So if we're trying to shoot more from a recovery standpoint than compensation, then we'd want them to be doing that step-through gait pattern up front as much as possible. So then, what types of patients do we think are appropriate for this technique? So, like Bree said, if they don't have enough muscle activation, then we can't do as many things standing as we normally would like to. So the general idea is that they have to have adequate lower extremity stability and adequate trunk control. So if they're falling over the harness, if they have difficulty standing, if they can't even sit on the edge of the bed or edge of the mat on their own, then this wouldn't be the best thing to start with. So those are things that we still need to factor in. And then what other things are important? So if we're trying to recreate the sensory motor components of gait, do you want them to hold on to anything with their arms? No, because most of the time people aren't walking holding on to anything. So the idea is that if we, like we talked about before, if we have to use a walking device for safety once they're home, like that's one thing that's a little bit different to keep them safe and prevent falls. But while they're with us, then we need to do as much as we can to focus on that recovery standpoint. So if they have a treadmill, don't have them hold on to the handles. Just because someone can walk with a walker early post-stroke, like why would we need to do that if that's not what they did before? Because then that's really just a compensation technique and it's not recovery. So if we need to help them out a little bit more, if we need to give them more support, that's fine, and until they can build up that extra trunk support and control. But again, if we have them walk with a walker, what do you think they'll get better at doing? Walking with a walker or walking without it? They get better at walking with a walker because of that specificity component. So if we teach them how to walk with a walker and do that day after day after day and thousands of repetitions, that's what they get good at. So what do you think happens when we take that walker away? It's terrible because they don't know how to motor plan. They don't know how to control their trunk. They don't know how to do all those other things that are required to walk with a more normal walking pattern. So again, from a compensation recovery standpoint, there's still a give and take. It's not like a super clear, guideline of do this and you'll get all of these specific results. but it's things that we need to be thinking about all the time for all of our patients. So what am I doing now? How does that affect their immediate performance? But what does that do for their long-term motor recovery too? Like, so yeah, they could go home with a walker. Yes, they could still use their walker at home, even outpatient, but is that really what we're trying to help them with for their long-term motor outcomes? Typically not. Again, thinking about inattention or controversive pushing or pushing syndrome, that obviously plays into having a slower progress through all of this, but once that gets a little bit better, we can still do all of these same techniques. Okay, so what about stair training? So typically, if someone didn't have any other conditions before a stroke, would they do one step at a time or both feet on the step? They typically would do 1 foot or that reciprocal pattern on the stair. So when we look at stair training, even if patients don't have stairs at home, stair training and that walking practice of the reciprocal pattern basically go hand in hand. So if we work on that step-through walking pattern, that translates over well into stair training, because what do they have to do in order to get their other leg up? They have to get 1 foot in front of the other. So the idea is that if we're working on the flexion component, we can have them lift their hemiparetic leg up the step and back down. If we're trying to work on extension or stability and stance, then we can have them move their unaffected leg up and down the stairs. So I typically start with just step ups, like non-reciprocal step ups from a safety standpoint, to make sure that the patients are safe to do this. But once we can progress them through these different patterns, then we can add in resistance. So let's say they can do a full flight of stairs fairly easily. Okay, well, how do we make it harder for them? How do we use these same components of walking and stair training to actually work on strengthening their legs as well? So that's where we look at using like a TheraBand for resistance. So if they're doing step-ups, you can put a TheraBand around their ankle, so now they have to lift their leg pulling against that TheraBand. You can add an ankle weight. So now you're adding 5 pounds to their weight of the affected leg. So again, the muscles are already weaker. Now you're adding more weight to it. Their body has to work a little bit harder. You can also limit upper extremity support. So again, if you're doing the step-ups on the trainer stairs and you're guarding them for safety, well, what happens now when they let go? So if they're holding on with their arm, do their trunk muscles have to do as much work? No, because they're using their arm for support. So take their arm away and see what their balance is like. So the idea is that we can change the specific variables of walking and stair training in many ways to facilitate recovery towards their prior level of function and challenge them from a strengthening standpoint along the way. So what do you think about, do our teaching methods impact patient performance? What do you guys think? Yes, they do. So what is one thing that all patients need in order to maximize motor learning and to fully participate in this process? Any thoughts? So in order to fully participate in the motor learning components of recovery post-stroke, what's something that they all need to be able to do to maximize that process? Any thoughts? So if we think about their cognitive status, they need to be able to have that cognitive ability to problem solve through what we're doing. So then that's where we have a quick overview of the motor learning components. So when we think back to when we were little kids, like learning how to crawl, walk, ride a bike, those are often the analogies that I use from patients to educate them on what the processes that their body and their brain is going through now. So when we, again, talk about learning, do you always learn right off the bat? No, it takes a lot of practice, it takes a lot of repetition, and that's what we need the patients to understand. So there's a few different or a few components of optimal environment for motor learning, and then something that's basically less than optimal. And again, if we go back to looking at that trial and error component and how the patients need to cognitively problem solve through, the different components go hand in hand. If we're asking our patients to, again, think about what they're doing, problem solve through, have to cognitively engage in what they're doing, how does it factor into how often we give feedback? Like if I give you feedback for every single practice trial that you do you really get that opportunity to think about what you're doing? No, because I'm giving you that feedback, I'm telling you what to do, I'm making or fixing your mistakes for you. So that's from that feedback standpoint. So the summary feedback and concurrent feedback talks about how often you're giving that feedback. So the summary feedback, they found 30 to 50% of the time. So give your patients, create a safe environment, let them have some mistakes, and then about 50% of the time give them feedback in terms of how well they're doing and what else do they need to change. Concurrent feedback would be the opposite if you're giving feedback for every single trial. So if you don't give them that time to think about what they're doing, they won't learn how to do this in a different environment when you're not there. Then the bandwidth and larger, smaller bandwidth goes in conjunction with that feedback. So if you think about the room for error is basically what bandwidth is. So a larger bandwidth is saying that, okay, out of 20 steps, you'll allow your patients to catch their toes on 50% of them. Versus a smaller bandwidth would say, okay, out of 20 steps, I'm only going to let you catch your toe once, and then I'm going to jump in and give you more of those cues. And there's no, again, the range would be like 30%, maybe 50%, but there's no specific standards in terms of each exercise because that's more of the clinical judgment. So again, giving them that room for error with that bandwidth component. Then external and internal focus, I think, is pretty interesting. So what they found is that it relates to how the brain processes the information. And when you give someone an external focus, an example of that would be if you're working on a golf swing. Okay, focus on the position of the golf club. Focus on like where you hit the ball. The internal focus would say, okay, focus on how you're lifting your arm up, where you're positioning your hands, how your arms are moving through the swing through. If you're working on a soccer kick, for example, it would be, okay, focus on swinging your leg back and hitting the ball with this certain part of your foot. The external focus would say, okay, focus on hitting the ball here and looking at where the ball will go. So there's a variety of different ways that we can factor that in. Walking and stair training, I think, is a little bit harder because the environment is moving all the time for walking. For stair training, I often just use like, don't catch the lip of the step. So not even saying don't catch your toes on the step, but saying like, don't like hit the lip of the step. So the more that we can have an external focus, it improves their brain's ability to problem solve and use all the pathways to improve their motor recovery. And then they also found that the farther away the external focus is, the better outcomes they had. So one example was with people who were kayaking. So saying, okay, focus on where the paddles are in the water. And they said, focus on where you're going like a half mile down the river. And the people with the farther away external focus actually had better performance than even the external focus that was closer. So again, there's a variety of ways that you can factor that into what you're doing. Even like for ADL practice, like don't maybe give them the cue of like, okay, this is how you hold it. Say, okay, focus on how you're opening the shirt to get the button in. So giving them the external focus will help a lot. Then if you look at random practice and variable versus massed and blocked, the main difference is that if you're doing 100 repetitions of that same task over and over and over, are you really cognitively engaged by the last 25? Probably not, because now it's more like a rote task. So the mass and block practice would be that you're doing a lot of repetition of the same thing in one time block. Then random and variable would mean that you're doing a variety of those activities in a random order. So for instance, for gait training, that would be walking forwards, walking backwards, walking sideways, walking over things, walking around things, going upstairs, downstairs, walking carrying something, walking with an ankle weight on, walking while you have to tell a story, walking while you have to turn your head. So from an ADL practice or upper extremity function, it could be doing a variety of ADL tasks in a random order and not in the same random order all the time. So in order to do that, they have to be cognitively engaged. So you're still getting in the same amount of repetitions as far as the high repetitions, but you're doing it in a random order. So instead of 100 times of buttoning a shirt, you'll have them button their shirt, tie their shoes, put on a sweater, cook something, or make a pot of, that idea of mixing up what they're doing instead of doing the same practice over and over. And then educating our patients on, if we're giving them a home exercise program, carrying the same idea over. So don't tell them to do 100 repetitions of this and then 100 repetitions of another in that order. Okay, here are 5 activities, do a few here, do a few there, and change up the order in which you do them. So if we're talking about how the patients are cognitively engaged, do you think we should be aiming for errorless learning? No. So the whole idea is that we need to be augmenting errors, again, in a safe way, but allowing the patients to work through and correcting errors to get them to self-reflect, think about what they need to do, think about how they need to fix it, so then they can carry these skills over to different environments. When they're not here in therapy, there's so many more hours that they're not with us than they are with us. So how are they going to carry these tasks over to when they're on their own? They need to be able to problem solve through, okay, well, I did this transfer here, these are the same components, this is how I can adapt them to a different environment. And that's also where doing the training in that variable or random practice comes in, because instead of doing the same flight of stairs over and over, bring them on a different flight of stairs. Instead of the same walking route outside, bring them on a different walking route outside. So the more practice they have in a variable environment, then the more likely they are to be able to be independent with these tasks. And again, safety first, but allowing them a chance to make mistakes. If we're working on balance, like giving them the chance to lose their balance so they can work on those riding reactions. If we're always holding on, they don't have to do as much work to keep their balance, and then they won't really get better at that component either. So in summary, the main idea is that the neuroplasticity principles, I think, should be an overarching component to everything that we do. So not that we need to hammer in all 10 to our patients, but those main 4: specificity, intensity, repetition, and salience, teaching our patients why that's important and how they can factor or use those components on their own, and then using whatever prognostic factors we have into our treatment interventions and motor learning. So why we need to structure our interventions to include those neuroplasticity principles and include those components of motor learning to minimize compensation, maximize recovery, and improve function. So it was a little long, but any questions on anything or?
So, quick question. How do you feel about, like, if you have somebody, an inpatient on acute, and you're ready for them to kind of go home, and you're doing probably like a lot of walking training, maybe like with an AFO, maybe not with an AFO, or like without an assistive device for the sake of training, but then when they're kind of doing that transition to home, keeping like neuroplasticity and motor learning in mind, what are your usual recommendations?
Like on how to make that transition home?
Yeah, like, because you did a lot of gait training without a walker, but now they're going to go home, and if they don't use a walker at home, would you rather have them using the walker at home and doing a lot of walking, or walking only when they're able to be with somebody to...
Right.
Yeah.
So you can just, let me see if I can... Sorry, just checking in with the... so Betsy's question was, how do you kind of go back and forth with recovery versus compensation and the neuroplasticity principles of safety? So I do think that this is something that there is no right or wrong answer, and I think that's why it's challenging, and that's why, like, I went back to kind of a lot of this research and things like that to figure out, okay, well, what are better things to do, because there isn't a set guideline for patients post-stroke. So I tend to go by what are their specific factors, like, do they have help at home, do they not have help at home? Again, there's no set guideline, so I explain to the patients why I'm doing what I'm doing. Like, I do want to maximize your walking as much as possible, but then let's also look at what's safe for you for home. So sometimes we have people going home using a wheelchair because they need to be able to be safe for like 8 hours a day. I'm like, well, your walking clearly is not at mod eye level, so unfortunately let's use this so at least you can be independent at home, focus on transfers, and then at least like be accessible that way, and then I'll focus on walking. I'll do more of that wheelchair mobility at the end. Same idea with the walker, like explaining to them, okay, right now, like your riding reactions aren't good enough to be independent. What can we do to help you get home versus having to go to a SNF? And then closer to the end, I'll introduce the walker, or maybe like a little bit each day for like a week or so. Again, that's more of like a general guideline. So that's a big discussion that we have a lot, is like how do we guide all that, because depending upon what families are able to help with, we don't always have the optimal environment for those neuroplasticity principles. So again, if family can't help enough, okay, I'll use those extra devices. So that's why I had put in that slide earlier on of like what all the factors come in. And so I try to, and from a rehab standpoint, we try to get as much time as we can. Like fortunately I've had some patients come in at like a max assisted stand, and then when they leave in 3 to 4 weeks, they're walking at supervision to mod eye level with either like a cane or something like that. So like now that I've kind of revamped my whole gait training standpoint, like I've been able to get more people up to that supervision to mod eye level. I don't know if that kind of, like, it's a tough. So I explained to them why we're doing what we're doing and how to keep them safe, and then having them understand, like, no, it's not the most ideal situation, but if you'd rather go home than go to a SNF, which is probably going to be a better option for a lot of the people we have, let's get you home and continue with all of this stuff in outpatient. And then you guys can carry it over, and then as they get more independent. But at least I've been able to get more progress in the 3 or 4 weeks that I've had patients doing this than like anything I did before. Ethan had asked, let me just read through this. So he was saying, the NeuroSig presented a clinical prediction guideline at the CSM, highlighting the importance of overground gait as being good or better than a lot of modalities for improving gait after CVA and TBI. Do any facilities in St. Luke's have body weight support systems to facilitate overground training so we can get the proper dosage? So on the ARC, Ethan, we do have that body weight support. It's on a 45-foot track, so it doesn't allow us to be in a different environment. It's just a 45-foot track on the one hall. So that's what I use a lot to get them over ground. So on the ARC, I don't have access to a treadmill. So on one hand, it would be nice when patients need more assistance up front, then I could be in one position and work on heel strike and prevent the knee hyperextension. But I don't actually have that. So we have the body weight support over ground. Do you guys, what do you have? Is it just over the treadmill? Okay.
We really want to unweight somebody, which
Yeah.
I don't actually usually want to do.
Right.
And I'll basically have them in the solo step off of a step, and then they
And then
basically
they'd
are
be-
body weight supported in the solo step, even though that's not what it's meant for, but
Right.
you can do it.
Okay,
But
yes.
yeah.
So then Betsy was saying in outpatient, she has access to like a harness for overground walking then too. And then, so for my practice, I've been using a lot of times I find the body weight for like a week, again, give or take, but if I've done like five, maybe 7 days of just body weight training and just getting the patients to have a lot of practice, again, provided they have enough trunk control to be upright in the first place, then, you know, the week after that or week and a half after that, I can do a lot more overground with potentially, sometimes I'll use the cane because I found that from an article, it improves the muscle activation and stance phase. So I tell them to use the cane as a light touch cue. So like, don't lean on the cane a lot, don't put a lot of weight through it, but just use it on the ground for extra sensory input. You know, handhold, I use the gait belt, you know, for extra safety. Ethan, I hope that answers your question. I don't know, any other comments or questions or anything? Okay, well, thank you.